Thank you. How are you today?
Good. Though I kept getting my times wrong somehow.
Oh, I'm happy that you were the one figuring out the times. So
Okay.
This interview, how many months have we been trying to connect? Probably since March, maybe? March or April for sure.
Yep. Yeah, it was, probably March actually. Yep.
Yep. So a long time. But so you're in Australia and are we 12? So it's 8:30 a.m. my time. What time is it your time?
It's 9:30 p.m. my time.
So it's bedtime. You're done for the day.
Actually. I was at boot camp at 6 a.m. this morning, so that's quite a few hours ago.
Oh, my goodness. Yes. Well, thank you so much for carving time out on your day. So I'm Janice Mitchell, and I'm a physical therapist, and this is Dr. Joe Milios, also a physiotherapist in Australia. So please tell us a little bit about yourself before we get started.
Okay, well, I have a 25-year background in physiotherapy, or physical therapy, as you say, up and over. We say we're down under. So I was a musculoskeletal physiotherapist for the first 15 years and thoroughly enjoyed myself. But I have a brother who's a urologist, and he was doing some of the first laparoscopic prostatectomy work in Western Australia. And he was quite keen to have a bit of physiotherapy support. So he asked if I was interested, and I actually thought it would be, something that would be a little bit out of the box. And it really appealed to me. I looked into doing some postgraduate research, but there really was nothing with men's health content. So I decided to just follow him around for a year or two. And between us, we developed quite a few systems and protocols that seem to work quite well for guys. And then men's health became something that I was doing 1 or 2 patients a week with, to now, at the moment, I'm running 6 days a week clinics, and just completed the PhD studies. I have it right here. I've only had it in my hands for one.
Oh, fantastic.
Like 3 days I've had it.
Wow. So, what a labor of love, too. What an amount of time and energy.
Yeah. So it's all quite an exciting time. I've just had opportunities to present my research at the Australian Physiotherapy Association annual conference. And before that, I was just in Geneva for WCPT earlier this year, where I met Karina Saracusa, and have really good opportunity to do some collaboration with her over some really exciting projects over the next 6 months or so.
I love it. And I saw you, the journal, the section on women's health, I saw that you're going to be teaching a course.
I am, yes.
So that was, I love seeing people that I know names. I'm like, hey, yes, that's exciting.
Yeah, it is exciting. I feel very lucky to have the opportunity. But yeah, I really love the men's health work. It's exciting. It's new. There's a lot of interest in it, particularly from male physiotherapists who are quite intrigued about how they can relate to their male patients, particularly if they've got sporting backgrounds and things like chronic pelvic pain. And then we do have prostate cancer as the most common cancer in men globally. So we have 1 in 6 men being diagnosed, and it's quite a hard journey for them, but my goal was to try and make it easier by translating some of the clinical things I'd learnt into simple sort of bedside tests and programs and protocols that physiotherapists could pick up quite early, or easily, should I say, with a good background of practice-based evidence as well as evidence-based practice.
Okay, good. So we're going to have several types of people following us. So one is providers. So we're going to have physical therapists watching this, but then also patients. Okay. So maybe we'll some content will be for both populations. Yep. So before we get started on the list of questions here, how could physiotherapists, how can they access the protocols and things that you've developed? Do you have a website? Like, what is the call to action for where a healthcare provider could find more information?
Okay, so essentially, because all my research has been in review for publication, I haven't really been able to share it very widely. So
Okay.
I've only just I've had 2 papers published that are in the Australian New Zealand Continence Journal, which are basically real-time ultrasound-based tests of pelvic floor muscle function that are clinical bedside tests that are quite easy to do either transabdominally or transperineally.
Okay.
Which you know, those are widely accessible. I've also just had the protocol that I developed for a fast return to continence and erectile dysfunction following prostatectomy approved for publication in a urology journal, BMC Urology, which will be, it's in press at the moment. So that will become available. There's also just conference proceedings which you can get access to, the Australian Physiotherapy Conference or Transform. Also, I presented WCPT Geneva this year. So
okay, so we go to that website.
Yeah. My own website at the moment doesn't have any of my results because, again, just the process of publication, you really need to keep things very close until that approval is granted.
Okay.
But,
so stay tuned. Stay tuned. We'll have.
It's not very far away.
Okay, good. And if people wanted to go to your website to find like patient content, do you have information on your website?
Yep.
And what is your website?
It's just Men's Health Physiotherapy.com.au.
Okay, very easy. And I believe that we'll be able to put that link also in the caption, so people should be able to click on that. So that's our goal. All right. Okay, so you told us a little bit about how you got into men's health. Now your PhD, give us a little more background on that.
Okay, well, I'll read you the title. Therapeutic Interventions for Patients with Prostate Cancer Undergoing Radical Prostatectomy. A focus on urinary incontinence, erectile dysfunction, and Peyronie's disease. So by therapeutic interventions, what that meant was I wanted to develop therapies that could be translated from research to clinical practice with just a little bit of education. So what I found was that originally when I started working 15 years ago is that most men were having incontinence for a good 6 to 12 months, and that because of the distress associated with that, they really had probably in at least 50% of the patients quite a poor quality of life. They were getting quite depressed, quite isolated, and men very, very challenged by wearing continence pads and the whole aspect of
sexual dysfunction.
Well, the sexual dysfunction was the thing that I really found most bothersome to men in the long run, and it was the one topic that wasn't being discussed with the urologists back then. It was like a no-go zone, and in fact, my brother and I used to have heated discussions, and he'd say to me, "Joe, I don't know why you're so bothered about sexual activity. The men aren't that interested." And I'd say, "Well,
yeah, right.
In actual fact, they might not be talking to you about it, man to man, but they're talking to me about it." And they're pretty distressed. And so I just decided then that the 2 side effects from prostate cancer surgery are basically incontinence and erectile dysfunction, that we anticipate like 99% of men will have both of those side effects.
99%.
We're expecting men to have them.
Yeah. And that's with a radical.
With a radical, and it doesn't matter whether it's the open technique or the robotic technique.
Okay.
There's such a dysfunction created by the removal of the prostate that you are anticipating to have some issues.
Because you're disrupting multiple structures when you take out that prostate.
I basically always say to guys, look, all of your life, your prostate has been providing urinary control automatically, and the prostate acts like the plug of the urinary system. And when that's removed, then your function becomes manual, and you have to learn how to work out what your specific triggers are, and then use the pelvic floor muscles in like anticipation, which are something that can easily be trained. But for most men that I meet, they have no idea they even have a pelvic floor. Right. So we have to really start very simplistically to get that sort of awareness and that specificity with knowing where the urinary sphincter is compared to the anal sphincter. A lot of the previous education, because pelvic floor muscle testing for men was always done per rectally, and the digital rectal examinations was something that men were not, jumping up and down in joy for having.
Yeah, exactly.
I really found it was important to try some non-invasive techniques of assessment. So that's where the real-time ultrasound fits really. And also, most men actually leak when they're moving, not when they're lying and sitting. So traditionally, all of our interventions have been to encourage people to do a fairly small number of exercises, just 3 sets per day. 1 set in standing, 1 set in sitting, and 1 set in lying. And I completely flipped that in my own research to say, look, let's start training preoperatively, not postoperatively. Let's try and utilise the time between biopsy and surgery, which is a period of at least four, usually 6 to 8 weeks. Let's start our exercises in standing. Let's do a combination of fast and slow twitch fibres.
Yes.
And let's do a number of reps over the day that is comparable with the high intensity workload that the pelvic floor muscle is going to have to endure without the prostate postoperatively. So in my own research, I basically compared 50 men who did the standard protocol, where they did 10 pelvic floor exercises in a set 3 times a day, in either sitting, standing or lying. And I compared that to men doing 6 sets of pelvic floor exercises, a combination of 10 fast pelvic floor contractions and 10 slower pelvic floor contractions, and all in standing. So there was 120 exercises a day compared to 30.
Okay.
So that was, the results of that were really positive, and that's a big part of the paper that's being published soon. But essentially, we did have on average 5 weeks preoperative pelvic floor training with the high intensity group, the standing group, having 1 in 6 men were not incontinent from the outset at all, following
really,
and 74%.
Wow! Will you say it again, please, just for anybody that might not have heard it?
So 1 in 6 men were never incontinent,
and that's of the group that did the 120.
Yeah, and so that was 14%, and only 4% of the usual care or control group, which is the 3 sets a day. So 1 in 25 versus 1 in 6 men became dry from the outset with the high intensity program, and 74% of our patients were completely dry and out of pads within 12 weeks of surgery.
Really?
Given that the first 2 weeks, once you've got the catheter in, it's quite quick. So the results were really, really positive.
Good.
And that was just on the continence side of it. The erectile dysfunction side of it, which was my main point of focus, the intervention I actually did over a 12-month period. What we showed at 12 weeks post-op in that initial phase was that because men were drier, faster, they were starting to engage in sexual activity and penile rehabilitation earlier. So their quality of life from 2 weeks post-op was significantly higher in the high intensity group compared to the control group. Although erectile function scores were not higher within those 12 weeks, this we found was most related to the fact that the nerve damage that's sustained because the nerves that wrap around the prostate are moved and stretched a little bit. They take at least 4 months to recover from a little bit of the neuropraxic effect. So in lots of ways, the 12-week protocol was just not long enough to make for a difference at that early stage. But although I was a little disappointed with that, if I had proved otherwise, it would have gone against everyone else's research and knowledge base that says it takes 3 or 4 months at least for the neurogenic effect to unravel. So the good thing was by 6 months, the high intensity group were far superior in their sexual function. And so, that was really good. So the therapeutic interventions include assessment of pelvic floor muscle function, which is non-invasive, which is more reliable, can be done in any position, and had high correlation between testers as well as from one tester repeating it. So really high correlations of about 97 to 99% reliable. So,
and that was real-time ultrasound transabdominally?
Doing real-time ultrasound, yeah. And the other thing is we do the DREs, and they are normally performed in supine or side-lying positions, and men actually don't have incontinence in those positions. So you're not really testing a true clinical picture by having men in these positions anyway, because they're really leaky in those positions. So
tell me more about DRE.
So the digital rectal examination.
Oh, okay. Yeah.
Yeah. So that was always the way to go.
Putting the finger into the anus to test the pelvic floor muscles. Mm-hmm.
And the patient has to basically squeeze the my digit. And as a physiotherapist, I give it a ranking out of 5, which is called the modified Oxford scale. But between one tester and another tester, it's quite variable and not that reliable. So we were able to show that the ultrasound tests, which simply measured how quickly men could perform 10 quick contractions, that's called the rapid response test. That's related to stress incontinence. So when a man coughs or sneezes or goes from sitting to standing, we want his reaction time to be really brisk. So traditionally, these fast twitch fibres have not been trained. So I wanted to get guys working on these from the very beginning, to perform them briskly, and to have a way of teaching themselves and training themselves. So it's a little stopwatch test, and it's just a case of men timing themselves. With me, they do it while they're looking at their pelvic floor in the ultrasound, but they can go home and try and practice that and reduce their times. So basically, if a man was doing 10 pelvic floor contractions and it took him 20 seconds, if you divide that by 10, it's about 2 seconds per contraction. So if a man coughs or sneezes and it takes 2 seconds to respond, typically he's already leaked.
Yeah, because that's 1, 1,000, 2, 1,000. And if it takes that long for the pelvic floor muscles to engage, to wrap around, you're already
so I wanted guys to be able to do the 10 rapid contractions in under 8 seconds, I worked out. If they could do it in under 8 seconds, 0.8 of a second per reaction, per contraction, then they didn't leak. So it's just
very nice.
The lethal muscle that they can train, just like any other muscle in the gym, or just by doing more reps. So that high intensity interval training is basically what we developed, and it becomes more like a reflex. But the brain is so clever that it's just neuroplasticity. If you give a training ambition, then we've got a highly motivated patient cohort that don't mind doing the training if that means they're not going to be wearing continence pads.
Exactly.
And similarly with the endurance holding or the sustained endurance test, I wanted men to be able to do a maximum voluntary contraction for up to 1 minute, because that potentially that's what men need to physically walk to the toilet to empty into the laboratory.
Because if they're only quickly squeezing, then they squeeze, but they're still walking, and you still need to have that engagement.
So I test men, and I said, right now, using your own stopwatch once again, watching on my ultrasound screen, but you can do it at home yourself. We just asked them to perform 1 maximal contraction, to keep breathing and to hold, and to sustain that for up to 1 minute. You can see on the ultrasound that the bladder neck starts to drop, or the bladder base, and that's when you stop the test. So they might only be able to perform a 3-second contraction initially, but you get them to gradually increase that. So it's just really simple tests, but they had functional applications straight away. And men like to measure, so they often bring me in spreadsheets and all sorts of things anyway. So that was really quite easy.
So for people that may not have ever heard of real-time ultrasound, basically it's very similar to the imaging that you would have like if you were pregnant and looking at the baby, except that we're using this tool to assess muscle function.
That's right. Yeah.
And transabdominally means that it's like on the belly, the lower belly. That's right. You're not having to take your pants off.
No.
Just lower them a little bit. So.
That's right. And then there is transperineal, and transperineal is still considered minimally invasive, but
Not functional.
Men do have to shift their testes and scrotum to one side, and then you place the ultrasound probe just underneath the perineal area. But,
and that's harder to do when you're standing and walking.
Yes, it is. But both of the techniques are actually viable, and I was able to show my research that, especially with these tests, it actually didn't matter which position you were doing them in, men were still contracting at the same rate because we were just simply measuring what they were doing.
Yeah.
So for women as well under 18 years of age, vaginal assessments are not considered appropriate. So the ultrasound is also really helpful for children and younger women. Also for potentially patients like men with continence pads who are, feeling embarrassed about it, or a menstruating woman, or
so many applications, or a history of sexual
patients.
abuse. Exactly.
Yeah.
Okay. No, you go ahead, and then I want to back up. I have a few questions about some of your research.
So basically, that was the main part of my trial. But then I got this sort of unexpected twist to my PhD, and that was when one of my patients knocked on my door one day. He was a younger patient who was about 45, and he'd had his radical prostatectomy 12 months earlier. And he was very upset, and he just asked if he could speak to me between patients. And you don't often get men knocking at the door, like, quite tearful. So I thought, yep.
Yeah.
Took him in.
Make some time.
He produced a photo of his penis. And what was happening was the penis was actually very bent to one side. So
instead of this.
Yeah, it was about 75 degrees curled and twisted to one side. So he was very, very upset about this. And he could feel a hard lump in his penis and said it had been painful. And he thought that his prostate cancer had returned. And I said to him, look, this is called Peyronie's disease, and it's not the cancer, but leave it with me and I'll see what we can do about it. I'll have a chat to my brother and see what to do. And what I discovered was that 1 in 6 men actually develop Peyronie's disease after prostatectomies. And that's because the blood supply that is eliminated for that first 6 months up to 2 years or longer. So without the blood supply to the penile tissues, the tissue starts to fibrose and shrink, and then these plaques develop. And then as the man's erectile function does start to naturally recover, when they get an erection, then there's this curvature that appears. And that is difficult to treat. So it has been something to confound neurologists and the medical fraternity for hundreds of years. And what they know is it's got 2 phases. So they've got an acute phase, which can last up to 18 months, where there can be pain and bruising and dysfunction. And the general treatment for it is not much, just to wait and see. Unfortunately, we know that only 12% of men improve, and the rest either get worse or stabilise. So long story short, I flew over to Chicago actually one Christmas to spend some time with my husband's family, who's Greek, and went out to dinner with Sarah Haag and Sandy Hilton. And that was all through the Facebook groups, actually.
Nice.
And I asked them about if they had any knowledge about this condition, and Sandy said, I actually saw 3 or 4 cases in my experience working in the military, and we just used therapeutic ultrasound and it seemed to work. So I took that home with me, set up a little pilot study, worked on this young patient. Within 10 sessions, we'd pretty much corrected his problem, and we had something called Doppler scans performed, which were able to assess the plaque, and there was complete resolution, so it wasn't visible on the Doppler scan anymore. So I ended up spending another 1/3 of my time doing another random control trial on using therapeutic ultrasound for Peyronie's disease, which I was glad to find that others had done case studies in the 50s, 60s and 70s. So there'd been certainly some positive outcomes in the past, and I just wanted to apply more modern technology. So it seems like therapeutic ultrasound is helpful for something like mastitis. It seems to be really simple for Peyronie's. So completely
fantastic.
as I say, it's the bend in the road of my men's health
Yeah. I
men's
love
health
it.
experience. Yeah,
Now, was it only
really important.
ultrasound, or did you do any hands-on stretching?
No, so during the random control trial, I was not allowed to do anything other than ultrasound.
Just ultrasound. Because you need to see what impact that intervention has. And if you're doing multiple interventions, then you don't know what helped.
Exactly.
Which is sometimes the case in therapy. Like, we do 5 things or whatever, and they're getting better, but was it because of X, Y, or Z, or a combination? So, yeah, that makes sense for research.
Yeah, so then I found that by applying, so once I had the ultrasound softening up the plaque, by then applying in the second part of the trial a vacuum pump, that would actually stretch the area that I'd softened, just like, so that was able to further correct the curvature. The interesting thing was anyone who had pain had complete resolution on it very quickly within usually 3 sessions. So some of these men actually had nocturnal erections that were painful because of restricted blood flow. And just simple ultrasound application really helped revascularize the area and soften the scarring tissue. I've had 3 other physios also working on it, dotted around Sydney, Melbourne and New Zealand, because I wanted to see, away from my treatments, you know, if others were having similar effects. So we found about 70% of the time the ultrasound worked well and decreased a lot of the quality of life things.
That's 7 out of 10 men. That's fantastic.
Yeah, and the ones that didn't work for, which we can now say, I'm sorry, but it's been too far, is that when there's been a calcification. And that usually means it's been more chronic, it's been there at least 18 months, and the ultrasound is not able to penetrate that. Unfortunately,
it's no longer painful at that point?
That's right, yeah. They can go on to have surgery to correct things. But the goal is, if we have conversations out there in the general public to say, if you're aware of some changes, then don't leave it. Go and get some
I'm creating
assistance.
a post in my mind right now as we're talking. So I want you to help, and let's make it together, because we've got to get the information out. And that's the whole thing about my account, is increasing awareness and being able to connect the regular person with their pelvic floor that may not have ever heard it, and pelvic health. So that is so fantastic.
And what I found was that 1 in 10 men across the board from other people's research have Peyronie's disease. It's a disorder that I've got patients from 18 to 88 with it. It's not that uncommon, but if you leave it, there's less likely to be recovery. And 1 in 2 men get clinical depression because they can no longer have sex, or it's painful, and they're mortified if their sexual function's not working. So, you know, it's something that any physiotherapist in the world could just pick up and do tomorrow.
Are you able to share what your ultrasound parameters are?
Yeah, I am.
Okay.
Yeah, because I've presented them at conferences now.
Okay.
So I can't give all my results away because that paper's in review as well. But
that's fine. Whatever you can share.
Yeah. So a couple of phrases that I've sort of made up to make the language more accessible to everyday blokes, as we say in Australia.
Yes.
I say your hard health and your heart health are related.
I like it.
and from Holly Herman, actually, I did her course in New Zealand in 2016. She was able to present some research that showed if men had some erectile dysfunction, potentially they had a 3-year window to check into the risk of cardiovascular events occurring, which is quite a long time. So essentially, if you've got any dysfunction in the end vessels, which is the penile vessels, potentially that's mirroring what's going on in the cardiac vessels.
It's an early warning sign. It could be an early warning sign.
You've got 38 months, quite a long time to access that. And,
to go get checked out. So then if somebody was having erectile dysfunction and it was new, they should go to their doctor and get their heart checked.
Yep. The simplest thing now is something called the coronary calcium score. In Australia, it's about $150, but it's a really simple test to give indicators.
Okay.
And just earlier this year, or late last year, the International Society of Sexual Medicine made it one of the risk factors for cardiac disease. So it's now recognised that if a man presents with erectile dysfunction, he should have a cardiovascular assessment.
Fantastic. This is just really exciting research, and I can't wait to work together and to be able to share this information more. This video will be on YouTube, but thank you so much for all of this. I know we didn't go exactly in order of the questions, but is there anything else that you'd like to share with people, that you'd like either healthcare providers to know or regular patients, people, blokes to know?
Well, pretty much, traditionally men have been very reluctant to talk about their private parts. They've also been reluctant to want to seek help. So sadly, there's a 5-year lifespan discrepancy all around the world between men and females. At least men are living 5 years less than women on average. So in Australia, it's 80 for men, 85 for women. Worldwide, I think it's 68 for men and 73 for women. If you go to Japan, they've got the highest life expectancy, but it's like 82 to 87. So it's just like we need to get men addressing their health issues earlier. We also know that men tend to bottle things up a little bit more culturally, again, by that whole masculinity kind of. I don't want to show my weakness. Yeah, toughing it out, and it's okay to seek help. In fact, you've got a much better option of potentially surviving a lot longer if you address something earlier rather than waiting for it to catastrophize. So men need to get talking about their health, talking to their sons and their brothers, and just within one generation. I mean, I've got 2 sons. The conversations that we have in our house is astounding, and the disagreements they have with their grandparents. For example, our Australian laws only allowed for same-sex marriage about 1 year ago. So there was lots of young people really proactive with that, and yeah, quite exciting. Yeah. There's so much to talk about in men's health, and we're just at the cusp of it in our profession. It's only new.
I know. I'm so excited. And if you look at where we are now versus 10 years ago versus 20 years ago, we've come a long ways, but there's still so much education and connecting people with their pelvic health and understanding the power and some of these warning signs. So remember, everybody out there, either if you're a male body, or if you work with male bodies, or if you love someone that has a male body, that if they're having erectile dysfunction, that they need to get checked out, get their heart checked out. So it was a cardiac calcification score?
Cardiac calcium score.
Yeah. Score. Okay. Cardio calcium score. And then if they had prostate surgery.
Coronary calcium score.
Oh,
coronary
coronary calcium score. I messed up too. I got the C's, but I messed up the name. Okay. Coronary calcium score. And then if they've had a prostatectomy, so where they've had the prostate removed, chances are very, very high that they have urinary leakage and sexual dysfunction, and that there's hope and help. You have some fantastic research and statistics, and go to Men's Health Physiotherapy.com.au. Okay, and so you'll get some information there, and you'll be adding more to your website, and we'll also have some links on our website.
Yeah, good. And also, I do want to work on a program. So I have a little not-for-profit charity in Australia called PROST. PROST means To Your Health. So if anyone wants to look up the exercise programs I run, it's just www.prost.com.au, and that's something that hopefully I'll share in the US at CSM as well.
Yes. Okay. So I'm going to be at CSM too. So we'll make sure that we connect, because I would love to meet you in person. It's going to be an exciting. So CSM is Combined Sections Meeting. It's an event sponsored by the American Physical Therapy Association. So you're traveling all the way over from Australia to see us, and we're honored that you'll be there. And I thank you so much for being a pioneer in this and for taking time. It's now past 10 o'clock your time, so we need to let you go to bed. Thank you for your excellence. Thank you for making time.
Keep it up. Your persistent emails.
I look forward to creating some engaging content and just getting the word out more. So thanks again, and have a great sleep. And I'm off to the start of my day. So all right. And we'll connect with you later. Bye bye.
Lovely.